Yeah, good evening. Thank you, Dr. Narsaraju, and all the members of Telangana State CSI for this opportunity. And it's indeed again a pleasure to hear Dr. Somraj sir's voice. Good evening, sir. And all the youngsters should learn a lot from him. He joined in. Many of our other colleagues, I think about 50 of them were logged in, but many could more take this example and join for our regular meetings. What Narsaraju asked is to share some of these principles of OCT and show some interesting case examples. And I was supposed to speak for 20-25 minutes and have some 5 minutes for discussion. This slide brings best wishes from Apollo Group of Hospitals. I'm always proud to present our FACS professional service colleagues who run services in multiple hospitals. Mala position is acceptable, but if it's significant one, again, we tend to post-dilate. That's where I think imaging maximum changed our outcomes. And then expansion, a minimal under-expansion of 10% is okay, but in a calcific disease, but if it's too much under-expanded, there could be more problems happening and follow. Other area where this OCT is being used more is bifurcation PCI, especially in the left main bifurcation. It goes a long way in assessing the lesion assessment, whether it is all the three, one Medina, or any of it is spared. If the side branch is spared, we could get away by using a provisional stent without going into a complicated two-stent strategy. I would take you through this imaging morphology of calcific vessels with some case example here. This is a 64-year-old female, hypertension, diabetes, dyslipidemia, has unstable angina and troponin, positive, and 2 months recurrent rest angina. But good thing was she had good LV function, but she developed right hemiparesis 1 month back, and she also had COVID recovered 2 weeks back. And surgeons were very hesitant there, both with a history of CVA as well as because of COVID. So he was referred here. So heart team approach we discussed with repeat surgery versus multivessel PCI. So as anyway, surgeons were not willing to operate, and the patient obviously, when we want, they always want the less invasive therapy. Good thing was the renal function was normal, LV function was normal in this lady. You see these angiograms carefully. There is a critical narrowing in the mid LAD. There's also narrowing in the proximal LCX and the OM here. The other views also show the same. We'll again see further. Then the right coronary artery again has a proximal vessel disease, and mid-RC also tight stenosis, but the distal vessel was okay. So good thing was the distally vessels were all right here, but he had a long segment calcific disease in all the three vessels. So this is the baseline pre-OCT. Why maximum usage of OCT was, you had to whether involvement of ostium of LAD and the left main was there, then it becomes more complicated to the procedure. So we wanted to make it clear and to see where the proximal positioning of the stent should be done. If you see it here, the distal extent was fine. And for the sake of time, I'm just running through the proximal portion also here. It looked relatively okay, where you had some space for the stent to be landed. We did this analysis calculations where we had LAD plaque morphology. You've seen this is fibrous plaque. This is how the calcific plaques look. What we measured is the thickness and also how much circumference of the arch it is covered, and depending upon which we take decisions. And this LCX ostial involvement and whether it is there, or left main whether it is involved. Luckily here the left main was all right. LCX ostium was all right. The proximal LAD, we had some space where stent could be placed, and the most critical was in the mid LCX. These are the areas we got. The left main area was very good. LAD proximally and LCX was also all right, not in the significant range. The most critical disease was in the mid LCX here. Area was 1.24. You have calcium, significant calcium all around here, and then the proximal areas are all mentioned here. The most important was in the mid segment. I would like you to take you through this. We did a live in a box case recording. For sake of time, I would take you to the most important phase and request you to listen
now
to
we
this.
dilated with a balloon because of calcium presence, and there's one point in the LAD showed circumferential calcium. And if you see there, the 2.5 NC balloon also didn't expand. 2.25 NC didn't expand. Then we went up to took another 2.5 NC balloon and expanded with very high pressure of 20. Still unexpanded portion you can see there. Still it is not expanded. Then now it has yielded at 20 atmospheres with 2.5 NC. Because we prepared the bed well, we took a 2.538. Intima to intima it showed 2.3 and to EL it showed 2.6. So we thought 2.5 into 38 stent we will place it. Checked the position to end that in the proximal hump. Then that's the final position. We inflated the stent. Distally it looks fine. Then because the long stent and 2.5 we took a 2.75 NC. Then serial dilatations are being given. Then the tightest portion where it had a block, we made it a point to cover it. That's the appearance which looks good. We wanted to study it with the OCT. The OCT picture shows expanded stent, but for the calcific zone. Now we wanted to make sure that osteal LAD lesion, what we left is not physiologically important. That is where we are taking the FFR wire now. We studied the RFR. RFR came negative. So we thought we could leave a LAD osteum like that. Now we went into LCX. LCX RFR is studied. LCX RFR, obviously distally it came positive. Both the lesions were looking important. The LCX being wired, dilated with the 2.25 mm balloon. You see the tight waist there, which didn't yield before. That's a dissection there. We were thinking whether to use only drug-eluting balloon, but for the dissection, then we decided to put a 2.25 stent. The proximal portion was a little troubling, but fortunately, signs we could track. The marker to marker advantage is again here at the osteal location. Then we inflated 2.25 stent there. There's no dissection distally. That's a 2.515 stent inflated. You see that the residual waste was there, which we inflated again with a 2.75 NC balloon. That is the appearance after the proximal. Now we are checking the RFR again. That RFR in both the sides came negative. That is the advantage of treating the proximal vessel if it comes important. And the OM flow is maintained, though lower division shows disease, but because of a normal thing, then we left. Now we have decided to go onto the right coronary artery. So this is the right coronary artery picture now. It shows two levels of disease, mid-segment tight disease and the proximal disease. Now after finishing the left side, now we hooked the right catheter with 5 French because also the spasm and the artery also looked small. 5 French JR catheter. As you see it there, the mid-segment long segment disease and proximal side stenosis. Another point I wanted to highlight this, in a team we always practice this, is when you're doing multi-vessel PCI, operator could get exhausted and it's always better to have another colleague who is equally competent and senior enough. So we always change, and now we become an assistant. The second operator becomes the main operator. Now we go on to right coronary artery. Hopefully we should be able to predilate and take care with a long stent. Because stent is still underexpanded even at 20 atmospheres NC balloon. There is some residual underexpanded balloon there, but we thought we have opened with 2.25, which could go. 38 mm Giants expedition tracked it so well, we thought lesion is open. Then we positioned it well. Just we didn't want to cover the osteum totally because osteum was free from disease. We wanted to do it from the conal branch. Next. Then we expanded 14, 18, but the residual waste at that point where we had a suspicion of the balloon was persisting. We didn't want to come out totally. We withdrew the stent balloon little, not to have distal dissection. We covered the proximal portion, which was again not stented, with a guide and tried to do little high pressure inflations here, but it didn't work. Next, then we have taken another NC balloon 3 into 10. We expanded. That went in easily, but the residual waste was persisting. That can be seen. We went on to further to take expand. Then there's a bigger balloon. We thought there's a balloon.
I think finally we took that OPN balloon. I'll specifically did it. It expanded well, and we did OCT run after. This is in LAD. It came all right. This is the most important difficult phase where that OPN balloon expanded at 40 atmospheres finally. That came out well. So initially, if you see this, again, poor man's stent with the stent boost, whatever you call, this is underexpanded stent. Initially, all the predilatations, it was underexpanded, OPN 40 atmospheres, then luckily the stent opened. So then we did a OCT run. Before, in between, we tried to do OCT, but OCT catheter couldn't go. Then afterwards, after the procedure is done, we did an OCT, saw that everything is expanded well. The stent is quite expanded. Areas were also quite good, as what is mentioned here. So, what is the learning point is how to decide each of these modalities have their own advantages in detection of calcium, but OCT is found to be best both in depth measurements also, which IVUS cannot do it. The risk stratification of calcification is done basing on the OCT findings. This is what is the score given. The maximum calcium angle, suppose more than 180, then it is more important. If it's up to 250, then it becomes all the more important. 360 degrees anyway, it is mandatory to prepare it well. And the thickness, if it is more than 5 mm deep, then it becomes more important. That's where I think we are getting to use IVL balloons. The calcium length, if it is more than 5 mm, if all of these are present, like in our case, then it becomes a little higher risk to tackle it in a better way. And as this shows, if it is mild, moderate calciums, we could get away with NC balloons. But if it is a significant calcium, that's where we take the help of the depth is more, you take also IVL balloon. If it is moderate calcium, probably OPN balloon will do the job. There could be some combinations. But what is important is to have all the required material in shelf and do it appropriately these patients. So take home message from this case is OCT imaging and physiology is important to get the results and also confirm it, like what we did in LAD and LCX. And lesion blood preparation is most important, shows in LAD. LAD we did dilate it well, and then with the stent went in well and results were quite good. But inadvertently, if you don't dilate the stent well, thought it is done okay, then stents nowadays, later generation stents are all right, track very well. And then it was dilated with a smaller balloon, stent could go well, but later on, once the stent is underexpanded, you land in trouble. Fortunately, the OPN balloon did the job here. There are some case reports now after doing stent also, people are going to IVL, but it's always better to have proper preparation, not to get into this trouble. I think that's the second RCA one shows what you should not do it, and the LAD one is what is ideal. That's what it shows. I would take about 5 minutes in showing this diagnostic utility of the OCT. I've run through for the sake of time. 59-year-old male, standard, all the risk factors, angina positive. He had before, and 5 years back, he had angina, is put on medical management. Now we came with increasing symptoms, and TMT was also strongly positive. He had little anomalous LCX. That is not the point of discussion today, but I wanted to highlight and show this aspect. This is something which is not very clear on an angiogram here. There is a lesion at the morbid distal left main or LAD proximal. Not very clear. We took multiple pictures. But in view of this occlusion of right was there even 5 years back. And this LAD, what we developed is new. So I was perplexed to see what is it, how is it important. Initially, we did physiology. The FFR baseline and the post-adenosine became very important in the LAD. Part of it, people could argue that is also perfusing the right coronary artery, but it became very important. That's where we explained to the patient and brought him for imaging. And then once the imaging comes positive, we explained that we would do stenting in that. This is the OCT catheter. We started imaging from mid-LAD to left main. So this is the point exactly. I try to freeze it at that point where it comes, but this is the point where the lesion was tightest. And then if you see here, that is a slit-like lesion he had. And the left main and proximal and distal LADs were all right. This is a particular point. If I try to freeze, that I think was the, before it crossed it just slightly. I freezed it here. That's the tightest portion. That's the lesion. So that's how we decided, and we went further just to have critical values in this left mains, LAD and LCX, probably 5.2 for left main, LAD 4 and LCX 3. And this is also important for us to when to leave it, like how I showed in the proximal vessel, the LAD was 5.5 there, so we left it. So this below this, then it becomes important both this physiological correlation with FFR values of these areas. And they always tend to compare with the proximal and distal vessels, also the plaque volumes and diameters and lesion length to decide many things. And clinical presentation of the patient also is important. We take the help of physiology also sometimes to confirm. The other things are routine. Once a lesion was thought of, then we wired and then stented it. Because we are doing such sort of lesion, we should make it everything absolutely sure. We did post dilatations also after the stent. And then we did imaging again. And that shelf-like thing, what is seen before, is now not there. The vessel also looks quite better. This is the OCT after the stenting. So this is the place where we thought the lesion was there before. Then this is the post-procedure OCT. I have freezed image, I would show it. And then we also again confirmed with FFR that now this time it became negative. So that's how sometimes when there's ambiguous appearances, OCT also helps along with the physiology. And later on, patient is doing fine, and this TMT also 1 year follow-up came negative. That's about calcific lesions and help of OCT in a diagnostic assessment. And now if time is there, I would also show 1 or 2 case examples of left main PCI where the bifurcation also has importance. Is it okay, Narsaraju, or shall I stop it here?
Yeah, please, Dr. Sreenivas, you can take 5 to 10 minutes. Yeah.
Okay. So I would show you this left main, how the OCT played an important role, especially when you're using bifurcation, there is no problem. Sometimes osteal left main, there could be sometimes challenges with OCT imaging. But I would show you 2 case examples, one of crossover stenting, one is 2-stent technique, which we used. This is not important here, but provisional stenting, how it works, for sake of time, we'll avoid this. And the various steps in DK crush, how the plot is important is all known. I'll take you through some of the steps. This patient incidentally was 69-year-old, also required TAVR later of the procedure. So this is in the pre-TAVR workup, actually we found that this patient had a bioprosthetic wall degeneration. He had severe AS, we were thinking, but he had developed also seen to have very critical left main, especially LCX osteum was also critical steno. That's how we decided to tackle this lesion first along with it, before the TAVR, because this ischemia is very important, a critical left main here. So then we wired both vessels, did pre-dilatation. This took a LCX stent, mini crush type, we did it here. I would then DK crush, first kiss, then LAD 1 stent was again put there. For the sake of imaging is our point of discussion, those are all the routine steps. We rewired again through that, and then did a second kiss. So the double kiss crush, what we call standard for the left main bifurcation. That's a result looking good in angiogram, but we also confirmed it with OCT again. Finally, the left main diameter looked big before imaging itself. We did a 5 mm balloon and post-dilated. That's the OCT run. This is the run from the OCT. The distal extent, as I mentioned, you should be seen clearly. There is no dissection distally because you have taken a little bigger, relatively bigger size diameter, and also keep the important, what is the expansion limit of the stents, we need to keep it in mind. And the LCX osteum, which we stented also, there is no osteal mesh, and there's not much of two layers. So LCX osteum was also well preserved. This is again seen clearly. In the left main, the area, what we got is 12.6. Because osteum of left main was not involved, we started the stent from mid LAD, went into middle left main to LAD and then LCX. That's how we confirmed that result was right. And the proximal left main was left without stent and area was quite good. Later on, after 1 month, we did a TAVR for this patient, and the patient came for follow-up and online consultation. He's doing fine. And this is another case. This is very such a critical left main disease also we could tackle in this era of interventional cardiology. Then we did live demonstration here. Very critical stenosis. We were worried, why did we select this case, sort of thing. But luckily, RCA was okay. LCX, we could wire it easily. But LAD, because of this eccentric nature of a plaque there, we had some issues. But we could first went into LCX, analyze the angiogram carefully, went into LCX, then we could go into LAD. Then LAD was also wired. Then because we wanted to do imaging, very critical narrowing, the catheter won't go. So we decided to dilate with this 2 mm balloon there initially. Then after 2 mm balloon dilatation, we checked the flow is okay. This is the OCT catheter being run from the LAD to left main. Then this is the tightest portion, as we see here. distal left main critical portion, what was seen here, very slit-like. And osteum of LCX, again, another important thing what we needed to assess was LCX osteum, whether it is important or not. If the plaque is not much, then probably you could do a crossover stenting. That was the thought process. And then the proximal left main was okay. Then lesion length we measured exactly. It came like 21.2. That's how we could take 23 mm stent and exactly place it right. So then discussion also said you should do imaging of LCX osteum through LCX also, to make it very clear that osteum of LCX is free. Then we took a OC catheter to LCX to left main also. Then we proved that LCX, which is a crossover stenting from left main to LAD. And there are multiple steps I would, for sake of time, I would quickly run through. And then that was appearance before. And then we also decided to do a pot with 5 mm balloon proximally before doing an OCT, because anyway left main was big as per dimensions measured before. This is the appearance of the after dilatation. There is a small shelf-like thing there. But flow was quite good. So this is the 3D stent rendering view, and the fly views, other things. There's bifurcation view. Osteum of LCX is seen very clearly. Those now recommendations are the struts should be dilated a little, but flow was good, and also osteum of L6 was seen very clearly in the OCT. And then we also wanted to confirm ourselves with FFR to LCX, and the FFR to LCX, this is the final appearance. LAD was good, LCX flow was also good. This is the final result. Then we did OCT and then FFR later. FFR came negative in the LCX. That's how it was appreciated well, and the patient came for follow-up also, is doing all right. So the word about OCT in bifurcation, it's very important to assess the branch. If it is a distal left main, you should always take it seriously. It also helps in planning your technique and doing proper position. There is some data coming up where you can predict about side branch occlusion. If the side branch angle is less than 50 degrees, then probably there's more, and the angulation of carina is more acute, there's more chances of side branch occlusion. Whereas if it is more obtuse like this, then probably the less chance of side branch occlusion. This is what is shown in this one of the studies. So this crossing technique of distal stent crossing is also very important. For sake of time, I couldn't explain all the details, but distal crossing will help in osteal stent also covering the osteum of LCX. That's how the provisional stents also do well. And this sort of distal stent crossing will be done possible, and also can be confidently demonstrated by using OCT technique. Before kissing, you'll stent struts across. After, then your struts will be free. Then if the struts are free like this, it will help in preserving the side branch results well. And if the struts across, people say there could be bridges forming like this, and that's how the LCX osteum tends to re-stenose. That's what is seen here. And osteal miss also, sometimes if you have it, you could see it very well. That's how LCX osteum plays an OCT imaging shows such crystal clear pictures, and we can confidently say that you have done a good job and the patients do well. This is a fly-through view, and where you see it very clearly. See this 3 bifurcation view. You see the angle of origin of LCX so clearly that you can be confident that no struts are crossed and the stent is covered well. This is a paper which highlighted all the importance of OCT. People, if you are interested, you could go through it, and this is a step-by-step OCT in bifurcation approach. I'm not going to details, but basically what we could show is how imaging helped in deciding whether to do 2 stents or a provisional stenting, and post-procedure imaging is mandatory. Last slide is to show, this is what I collected from the literature. I couldn't find all the examples from our lab. So this is various types of instant restenosis, what is described. Depending upon the type of pathology, you get it. You decide whether to use only cutting balloon, or you use a second, only drug-eluting balloon, or a second layer of stent. Then there's more of the plaque than proper preparation, and probably more plaque inside, then you have more usage of a second different type of stents. That's how it is. And finally, to conclude, what I have shown is OCT has both pre-procedure diagnostic implications in lesion morphology assessment, And probably post-procedure, that's where Max concept helps to do precision PCI and also get the maximum results. And special subsets like left main bifurcation and instant restenosis, that's definitely a significant role. And when a combination of imaging, also physiology also could be necessary occasionally to confirm results. Our lab should be well equipped with all modalities and devices, especially when you're providing effective therapy for not only erstwhile surgical cases, but even many of the patients being referred from surgical turndowns or surgical colleagues also request us to help these needy patients. I think that's how we are able to do a good job with all the technology available with us. Thank you very much. I request all to block your dates for the coming TCT. Thank you.